Good morning, everybody. My name is Doron Keshet. I work here in Rambam. It's very nice to see a lot of familiar faces. And we'll spend the next few minutes talking about frontal plane single level deformities planning. It will be hopefully simple and clear. So when we come to talk about frontal plane axis planning, we have to remember the first and very crucial principle that Marie talked about at the very first talk this morning, that anatomical and mechanical axes of the femur are different, okay? With the difference is described as the anatomical mechanical angle, and its population average about 7 degrees with a range to 5 to 9, but I think remembering 7 is a good number to work with. And when we talk about frontal plane single level deformities, we have to understand that we can use two techniques, that we can do anatomical axis planning as described before, or mechanical axis planning. On this talk, we'll focus on mechanical axis planning, because also keep in mind that at the end, our end goal is to have a mechanical limb alignment, so we're going to use this technique. So to identify the apex of the deformity, we first need to draw two lines, the proximal femur mechanical axis and the distal femur mechanical axis. I remind you this is a single level deformity, okay? So we have two strategies to identify the proximal mechanical axis. The first one is called the three-line method. I will go over it. The second one is when we create a normal mechanical lateral proximal femur angle. So let's dive into it a little bit. So the three-line method, first we draw the proximal mid-diaphyseal line of the femur, the blue line here. Next thing, we measure the anatomical medial proximal femoral angle to check for no hidden deformity, okay? And we see here, it's within the normal region, 87. Then we draw a second line that starts at the center of the femoral head and is parallel to the diaphyseal line. We can do that easily with all the PAC system we have now. And then we draw a third line that starts at the center of the femoral head and creates a sevil angle with the second line, again to mimic our AMA. Okay? So this third line, the red line, represents the proximal mechanical axis of the femur. And here you can see we use the same principle like the basic anatomy for creating this proximal line. So the second strategy is when we can use the normal mechanical lateral proximal femoral angle. We draw a line and we make it an average, like 90 degrees population average, and we created this line, okay? What about the distal mechanical axis? Also here we can use two strategies. First one is normal tibial mechanical axis, and the second one is normal mechanical LDFA. So normal tibial mechanical axis strategy can be used when we have normal or near normal MPTA, and we have normal or near normal joint line convergence angle, which in general means joint line obliquity. If those two criteria are met, the normal tibial mechanical axis is extended into the femur and serves as the distal mechanical axis of the femur, represented here by the blue line. Alternatively, we can use the normal M mechanical LDFA if the MPTA is abnormal or unavailable, or the JLCA is abnormal. How do we do that? We use the distal joint line to draw a line from the center of the knee that creates a normal mechanical LDFA of population average 88 degrees. So now we have another strategy to draw this line. So how is the apex affected by each proximal mechanical axis strategies? You can see here two lines. The dotted line that we used is the three-line method. The other regular red line is we use the normal mechanical axis, and we see that they differ a little bit. In this case, we use the three-line method is preferred. It's more close to the apex. So our next steps, we mark where the proximal and distal axis line intersect. That represents the apex of the deformity, as we learned before. We measure the magnitude of the deformity. It's 30 degrees at this case. We mark the bone cut. That's the B. And we align the proximal and distal axes. In this case, it was an acute correction. We check the alignment, and now we have normal LPFA and distal femoral angles. And that's before and after the correction. So let's use one clinical example for single limb deformity. This is a case also from the Baltimore course. This is a 16-year-old female developed right genovalgum and right knee pain. So for the purpose of this short talk, we'll only focus on the right femur. So we need to identify the axis of the proximal femur. We will use the three-line method that was just learned. We check the MPFA, and we see that is normal, so the three-line method is valid. We can use it. We draw this parallel line, the 7 degrees line, and this is the proximal femur axis, right? What about the axis of the distal femur? So here, the MPTA is 92 degrees, and we learned from Dr. Herzenberger that we have the good combo, bad combo, so we'll accept that. And the joint line convergence angle is within the normal range, so we decided to accept that. So we extend the tibial mechanical axis approximately into the femur, and that will create the distal femoral angle, okay? The distal femoral axis. Now we mark the apex of the deformity, and we can see that it's really close to the joint line. We measure the magnitude of deformity, 16 degrees in this case. We have to decide about the bone cut. What do we do here? We plant the bone cut above the apex, but as close as the apex as possible, because we learned we want to minimize the translation. But also we have some practical reasons here, rationale. The bone cut level will keep us out of the joint, above the suprapatellar pouch, and also allow us enough room for fixation. So sometimes we have to put in some practical reasons when we make our bone cut. We perform the correction acutely or gradually. In this case, I'll show you what was done. So this is preoperatively, osteotomy was performed, fixated with a monolateral fixator, immediately postoperative X-ray, and this is 4 years postoperatively. You see good mechanical axis of the limb. Thank you. John, I think you're going up for double level deformity.
Any question to Doron?
That was an acute correction with the monorail, I think.
Why was the frame not like a plate?
It wasn't done by me, so I cannot answer that. Maybe I think it was done by you. So maybe John can answer that.
So that's an old case. My practice has gone on for 37 years, and I used to put on fixators on everybody, and that's how I got my name famous in orthopedics. But now that I'm older and wiser, I try to put on the least number of external fixators that I can, and I use plates and rods and internal fixation. But the principles are the same, so it doesn't matter if you're doing. And I'll tell you the dirty little secret that we have as limb reconstruction surgeons. Everyone looks at these external fixators, these circular frames and monolateral frames, and they think this is Star Wars and so complicated. But the secret is that it's actually silly surgery. Anybody can do it, because if you put on a fixator, it doesn't have to be correct. You could adjust it afterwards, you can modify it, you can have the computer program the hexapod. It'll make up for any deficiencies that you as a surgeon have. But on the other hand, to do a well-done carpenter-style osteotomy with internal fixation that's no longer adjustable, you have to leave the operating room with that bone as perfect as it can be. So the true master surgeon is not us who are using X-Fix. It's the guys who are doing plates and rods and getting good realignment. That's more challenging. We're going to later have a lecture about something in between that we call fixator-assisted plating and fixator-assisted nailing, where our secret is that we use the fixator to get the correction, and then we put on a plate. So, okay. So this, by now, I think your heads are spinning around and you're thinking, oh my God, why did I sign up for this course? I'll just point out that we do have, this is the one-day version. We have a 3-day version in Baltimore, and there's cards out here. So anyone who wants to come in August 19th to the 23rd, 2026, we do this in a little more slow fashion with workbooks, and it's highly recommended. Understatement. Okay, let's look at this guy. This is a lot of soft bone diseases like rickets will cause a bowing deformity. So if you've got a bowing deformity like this, where's the apex? And you can do the analysis that Doron just showed us. And I'm going to show you, he showed you mechanical axis planning, but I like to use rods, IM rods. And if you're using IM rods, your rod has to go through the center of the bone. So it's a little bit better and easier to use a method of planning where you're drawing your lines in the bone where the rod is going to go, instead of mechanical axis, which is in the bone distally but outside the bone proximally. So we can do anatomic method planning. We can draw a mid-diaphyseal segment up there. We can measure the MPFA just to show us that there's no hidden deformity in the hip joint. And we can draw a distal line over here and measure that against the joint orientation angle. It comes out to be 81 degrees. That shows us that there's no hidden deformity. But what's wrong with this? If the intersection of these two lines, the red line and the blue line, is not in the bone, it's outside the bone. And anytime you see this where the intersection of an anatomic line in planning is outside of the bone, it means, the little bells should go off. It means that you are dealing with a second deformity, at least a second, maybe even a third. So here's the intersection that's outside the bone. And you could correct it there, but if you do that, if you do the correction there, you're going to get what we call the golden arches effect, right? Like McDonald's. And so you can't get a rod down that. So that's not going to be a very good method. I don't want to use a rod. I like rods, so I want to put IM rod. So if, we've got to go back and say we're missing something. What we're missing is that in the curve there's really you can break it down to two or sometimes more deformities. So if we go back to this line where we have our intersection of the proximal and distal line that's outside the bone, we can add a third line that'll be a mid-diaphyseal line somewhere here. And now we have two apices. We have a proximal apex and we have a distal apex. And so you can measure what the magnitude is of each of them. And you actually, a curve could be like an infinite number of straight lines. But there's, as surgeons, we can't do an infinite number of osteotomies. So you have to do something that's practical. So practical would be to do two osteotomies. We have apex 1 and apex 2. And they both have different values, 26 degrees above, 22 degrees below. And if we do our bone cuts, and we're going to try to sneak an IM rod down this, we don't want to have any obligatory translation. So we want to do the osteotomy exactly at the level of the apex of the deformity, exactly at that level. So we have bone cut 1, bone cut 2, giving us apex 1 and apex 2. And then if we correct it, now we can somehow sneak an IM rod down that and fix it. So that's why I like to use anatomic axis planning methods and anatomic axis lines in the femur when I'm planning out my corrective surgery if I'm going to use an IM rod. And I do have a case to show you. This is a clinical case example of a bowed femur. And we use the anatomic axis planning. So there's the MPFA of 88 degrees, which is normal. And we can have a distal anatomic LDFA, not the mechanical LDFA, but the anatomic LDFA, which is usually about 81 degrees. Here it's 76. That's within just about the range. And so we draw an 81 degree line and we'll get one intersection, but we know in a curved bone we really need to have two. So we draw a third line that gives us two apices, two intersections, and A1, apex 1, apex 2. And now we can take that information to the operating room, make two bone cuts, and put in this case, a retrograde IM nail with the two osteotomies. Because you're doing an acute lengthening of this bone, you may want to remove a little bit of bone on the lateral cortex to take some of the tension off of the neurovascular bundle. And this is what it looks like 4 months post-op. And we did a similar case yesterday at Rambam. So this is what double level deformities look like in the femur, and how the analysis works. And if there's any questions, I'd be happy to answer them. Thank you.